Hi, morning everyone. This is Kelvin. I'm from SUSS, the Masters and PhD in Gerontology Program. Welcome to our event today on the creating an age-friendly environment and community. I'm delighted to welcome to you this symposium on creating an age-friendly environment and community, which is co-organized with URA and NLB. This is the first time that SUSS is holding a special session with esteemed presenters from our partnering organizations, Simon Fraser University, URA, SingHealth Foundation, Khoo Hospital, and thank you again to our partners, our co-organizers for making this event possible. This morning, we have a very packed program till 11:30 a.m. And without further ado, I'd like to welcome our guest of honor, Mr. Kiat, Minister of State in the Ministry of National Development. He will be appointed as the Minister of State in the Ministry of Communication and Information, in addition to his present portfolio at MND on 15 May 2021. Mr. Tan is no stranger to SUSS. He has been very supportive of our gerontology students in the master's program. In the latest tie-up, he has linked with his grassroots leader to our students doing their course on aging families, multi-generation and multicultural issues. 13 families and 64 students have interacted on the ground with seniors and caregivers in Kampong Chai Chi. So, Mr. Tan, welcome again. The floor is yours.
Thank you. Good morning.
Thank you. Thank you for inviting me, Dr. Kelvin Tan, Senior Lecturer, Master of Gerontology Programme, Dr. Habib Chaudhury, Professor in the Department of Gerontology, Simon Fraser University for Canada. Speakers, panel moderators, ladies and gentlemen. A very good morning to everyone. I'm very happy to join you today for this seminar on creating an age-friendly environment and community. I'd like to thank the Singapore University of Social Sciences for organizing this session. This topic is particularly relevant in Singapore's context. Our population is growing. People are living healthier and longer lives. In 2030, 1 in 4 Singaporeans will be above 65 years old, compared to around 1 in 6 in 2020, which is around last year. We want our seniors to age with dignity and lead independent lives. To better plan for this, the government launched an action plan for successful aging in 2015. We aim to cater to the diverse needs of our seniors, from creating more work opportunities to ensuring that they have access to affordable healthcare and care services, as well as improving their living environment. A key challenge of an aging population is to ensure that our public spaces and infrastructure are thoughtfully planned and designed. A recent HDB survey in February this year found that 86% of elderly residents intended to continue living in the existing flats. What this means is that 1, our infrastructure and systems must evolve to adequately support our changing demographics. And 2, we must do more to enable our seniors to comfortably age. We are already taking steps to make our urban environment more senior-friendly. Let me briefly elaborate on some areas and initiatives. It's around the community care apartments.
Station, Chinese Garden.
Recognizing the need to expand the housing options for seniors, MND and HDB and MOH started the community care apartments. This new concept integrates senior-friendly housing with care services that can be skilled according to local needs, as well as social activities to support seniors to age independently within the community. For example, these flats will have senior-friendly fittings to allow residents to move around more easily. And there will also be communal spaces on each floor for residents to mingle and make friends. There has been a very positive response to this pilot project. The sale launched in Bukit Batok in February earlier this year. We received over 706 applicants for 169 flats. That is around 4 applicants for each flat. Given the good response, we are now starting plans for a second pilot site, and more details will be shared when ready. But this is not the first time that HDB has built a senior-friendly development. In 2017, we completed Kampong Admiralty, a one-of-a-kind integrated public housing development which showcases how seniors can live healthy, active, and meaningful lives in HDB towns. It features flats for seniors with facilities such as a medical center, an active aging hub, dining and retail outlets, and a community farm, all under one roof. Kampong Admiralty was very well received as well, and agencies are currently developing a second such project at UT. We recognize that there will not be a one-size-fits-all solution or option. We'll continue engaging the public and stakeholders to adapt our housing options to support the lifestyles and healthcare needs of our seniors. Many of our seniors express a preference to continue living in the existing homes, and we will need to ensure that our HDB flats, public spaces, and infrastructure are designed to be senior-friendly as well. For instance, through the Enhanced for Active Senior Program, or EASE, households with seniors can retrofit their homes with items such as grab bars, slip-resistant treatment to bathroom floor tiles, and ramps at subsidized rates. At a precinct level, HDB has also incorporated universal design in their towns to make the living environment more inclusive. For example, by incorporating gentle sloping ramps and barrier-free access. We'll continue to partner the community to do more for our seniors. For example, NParks has been progressively opening the therapeutic gardens that have senior-friendly features. These gardens are specially designed to provide respite and improve the mental well-being of all visitors, including our seniors. By 2030, in 10 years' time, we will have 30 of such gardens across Singapore. On our roads, LTA has introduced silver zones across the island to enhance the road safety for seniors. This involves implementing a series of traffic calming measures and senior-friendly road safety features at areas with a high proportion of senior residents. We have seen accident rates within these zones that have gone down by as much as 80%. So we have a good foundation in place, but we cannot rest on our laurels. We must always look ahead and adopt new urban living solutions and innovations. We are investing in R&D to enhance our urban landscape and improve our infrastructure to support the needs of our people. In 2017, URA commissioned two large-scale research studies on how the built environment influences the well-being of seniors. One study looked at how our public housing neighbourhoods can be safer and more conducive for seniors. And the other, we look at how nursing homes can be made more person-centric and better integrated into the community. And both studies involve researchers working with the built environment professionals, like architects and planners, as well as the community to co-create design ideas to make the environment more senior-friendly and inclusive. In conclusion, let me just say that it takes a whole-of-nation effort to build a more inclusive Singapore for all of us. I've outlined steps that we are taking to make our living environment more senior-friendly and how we are nurturing communities of care to support our seniors across various aspects of their well-being, physical, emotional, and mental. Our seniors have played and are continuing to play an important role in Singapore. It is our duty to ensure that they continue to live well and enjoy their golden years. And seminars like this bring together experts and leaders, not just in Singapore, from around the world to discuss this important topic. I wish all of you a very fruitful and insightful webinar this morning. Thank you very much for having me.
Thank you very much again, Minister of State, Mr. Tan. We shall now invite our keynote presenter, Prof. Habib. Dr. Habib, Professor in the Department of Gerontology, Simon Fraser University, Canada, has extensive research experience. And today, what he's going to share with us is going to be key to us in terms of physical environment for people with dementia in long-term care facilities, memories of home and personhood in dementia community, planning and urban design for active aging, and dementia-friendly communities. So may I now invite Prof. Habib to share with us this important topic.
Good morning, everybody. Thank you so much, Dr. Kelvin, for this invitation. I want to thank the SUSS Gerontology Programme as a main organizer, other organizers and partner of the symposium. It's my delight to be here sharing with you a presentation on dementia-friendly communities and the built environment. So I want to talk about dementia-friendly communities and built environment and in a broad way to talk about the principles, some case studies, and also about the importance of the built environment. So one thing at the outset to note is that dementia-friendly communities is also known as dementia-inclusive community, and it can be considered as part of the age-friendly communities movement. At the same time, it's very important to recognize that dementia aspects are important enough and they're distinct enough to make this a parallel movement with the age-friendly community. So there's overlap with age-friendly communities, but dementia-friendly communities movement has other aspects that need to be addressed. So I'm going to move forward in the interest of time. I may speak a little fast, so bear with me. So the overview of my presentation is that I'll talk about the dementia-friendly community principles as we know from Alzheimer's Disease International and some other international organizations. I'll talk about a few case studies from across the world. And then finally, I'll touch on the importance of the built environment, talk about some of the design principles, planning and design principles, when we talk about the importance of built environmental interventions as part of DFC. So just to give you the context, 50 million people are living with dementia currently, and this is rapidly expanding. It will be 130 million by 2050. As we know, as people are growing older, rapidly aging across the world, including Singapore, aging is connected with the number of dementia. We know 1 in 3 over 85 have dementia. So as people are growing older, societies are getting older, we'll have more people living with dementia in the coming years. We also know that approximately over 70% people living with dementia worldwide live in their homes in the community. So this is a critically important context, the community context, the neighborhood context, to really support people living with dementia in their activities, in their quality of life. So given the context of the community, we have to recognize the physical built environment of the neighborhood and, of course, the social environment that shape the experience of people with dementia. And connected to that issue is the aspect that dementia is not just a health issue, it's really a major social issue. And we talk about interaction with neighbors, support from neighbors, community-based programs. These are social aspects of dementia. So given that context, we have to recognize there's a wider community has a responsibility. It takes a village to support a person with dementia. And we really need to really do our part in the community to be inclusive of people with dementia. So this is a definition from Alzheimer's Disease International, and there are other definitions, but broadly, dementia-friendly communities are defined or referred to as a dementia-friendly and inclusive community can be defined as a city, town, or village where people with dementia are understood, respected, and supported. So this is like a overview, 30,000 feet overview of a definition and goal of dementia-friendly community or dementia-inclusive community. This has got many principles and many sub-aspects. To dive deeper, let's look at the core principles of DFC as identified by, again, ADI or Alzheimer's Disease International. So these 4 principles are awareness, education, and eliminating stigma, empowering people with dementia and achieving social inclusion, improved care and services, hugely important principle, and collaboration as part of the process. How do we really achieve the first 3? So collaboration among different entities, different government entities, non-government entities, community-based organizations, that's a critical part of achieving the other principles. So I'm going to touch on each of these principles briefly. The first one is addressing, I'm just trying to move awareness, education, and eliminating stigma. So this is a hugely important first step, and it can be considered as a foundational principle. And without this, really nothing cannot be achieved meaningfully. So it includes the issue of increasing dementia awareness and sensitize others to needs, challenges, and solutions through education training. So this has got several aspects. It starts with the dementia awareness and education among the general public at a foundation level. But we need to move beyond that and talk about targeted dementia awareness, and that can include retail, business, services, organization, so on. So for example, a person with dementia going to a bank and interaction with the bank teller, the bank teller needs to understand what are the challenges a person with dementia might face in terms of communication and other cognitive issues, and be responsive, appropriately responsive to those needs. Same goes for bus drivers or taxi drivers or the cashier at a store. So there are different levels of sectors in the community that have different responsibilities in terms of dementia responsiveness. But at a fundamental level, this is dementia awareness, but this needs to be customized depending on which sector within the community we're talking about. And then this leads to the focus of fostering inclusion, dementia positivity, acceptance, and normalization. So these are abstract, large words, but they carry a lot of weight because we need to talk about inclusion in a meaningful way. We need to talk about acceptance, and not just acceptance, normalization as much as possible in terms of normalizing the activities and engagement of people living with dementia. The second principle is empowering people with dementia, which is, again, a highly important principle. This is about facilitating self-determination, autonomy of people living with dementia and enabling them to assert themselves. So this is critical in terms of whatever we do, any program we can think about that is meant or to support people with dementia needs to include people with dementia. So for example, the international organization, Dementia Alliance International, their motto is nothing without us, nothing for us or about us without us. So that's coming from the disability movement, but it is really applicable for dementia-friendly communities aspects. So highlighting people's rights to participate in identifying needs, priorities, and solutions for DFC. So whatever we are doing, it's not just thinking about how can we include people with dementia or the importance of people with dementia, but also the process of how we are engaging people with dementia in a meaningful way. And that leads to the third item, rejecting tokenistic notions of participation inclusion. So this is actually coming from a study in Canada where people living with dementia have remarked on their involvement in some of the programs and activities in the community where it was felt that their participation was a tokenistic political perspective rather than a meaningful perspective. So we really need to think about the empowering people with dementia in a way that their participation is a much more meaningful engagement rather than a tokenistic and a formal aspect that would really defeat the purpose. So the third principle is obviously a huge one, and this has got several levels, and we don't have time to go into all of those, but I'll try to cover a few important ones. Improving care and services. So the first part is about early diagnosis. This is the critical issue in all across the world about early diagnosis would help people with dementia and their caregivers to really receive support and treatment and other facilities in earliest possible way. This connects to early diagnosis connects to having the support services for GPs and also dementia education for people to go beyond the dementia stigma or resistance about being diagnosed with that. So there's a lot of educational component to this early diagnosis, in addition to the healthcare support that needs to be in place in the community. And then the other part is, of course, post-diagnosis support. This is also a large issue about to what extent we have appropriate support for people with dementia and their caregivers moving forward after the diagnosis. So this goes much beyond the doctor's office, obviously. The second one is focusing on total health and well-being of persons living with dementia and carers. So total health and well-being really refers to not only dementia as in terms of behavioral issues or behavioral challenges that people might face, cognitive challenges people might face, but how do we look at the overall social well-being, psychological well-being, and spiritual well-being? And I want to underline the term carers here, carers or caregivers, because quite often they are not appropriately included in many programs. Because of course, the main target group or main involvement group would be people living with dementia, but carers are integral partners of this movement and really have to look at what are the ways that we can meaningfully support caregivers. For example, in Singapore, 60% of family caregivers are women. And we know many of these women have sacrificed their own careers and jobs, and that really warrants special support for them. And this is we need to ramp up whatever programs that are in place to support caregivers. One big aspect under care and services is obviously community-based support services, which include many things, including dementia day programs, memory cafes, home support, and care. So each of these are distinct programs in their own right. And they really are addressing the issue, how can we support people with dementia to age in place and have the maximum quality of life possible. And finally, on this slide is the focus of making homes, hospitals, nursing homes, and neighborhood environment dementia friendly. So this particular aspect is about the built environment. And we need to look at each of these scales to make them more dementia friendly as we move forward. So the last principle that I'm touching on is the collaboration among different sectors and, of course, persons living with dementia to educate, raise awareness, and develop plans for action. So all the principles that I'm talking about, the first three principles, would need collaboration. This is the mechanism in which those principles can be achieved as best as possible. There are many dementia-friendly community initiatives, action plans across the world in different communities, different cities. And many of these initiatives or action plans include community stakeholders, policymakers, and persons living with dementia. The challenge really is the collaboration in a true, meaningful way. It's one thing to have these different stakeholders, policymakers as part of a steering committee. It's a different thing to really make collaboration work in a meaningful way. And that needs a lot of good leadership and commitment. And finally, on this slide is the importance of understanding community assets. So it's not just top-down approach from municipalities and government bodies or NGOs. We really have to look at carefully community assets and how can we really meaningfully develop partnership with existing communities or supporting new community-based groups and organizations, although they may be quite informal initially. So I'm borrowing this image from Alzheimer's Australia, a report from Alzheimer's Australia, which really addresses the mechanism of what I'm talking about, that at the core is enhancing, supporting the lives of people with dementia. And at the next level is these social inclusion, issues of stigma, improving care and services, awareness, and so on. But these are achieved through these interaction of communities, partnerships, and organizations. So communities are really the actual communities in place in the larger, broader community, Organizations need to come together, businesses, medical communities, and other community organizations, and really create partnerships to really make this work in a meaningful way. So moving on to the next segment of my presentation I want to talk about a few case studies briefly. There are many good case studies across the world, and Singapore is actually one of them. So I want to touch on briefly on some of these. There are many countries that have Dementia Friends program, which is basically having a training and education program for people to learn about dementia and understand the challenges and issues with people with dementia and take action to improve the lives of people with dementia in the community. So as I mentioned before, it starts with an overall education for the public in general, but it goes beyond that very quickly into targeted education to retail, commercial, service providers, first responders, law enforcement, and so on. There are memory cafes, and there are different names of memory cafes, like Alzheimer's Cafe as well, in many countries across the world, including Singapore. And these are informal events and settings in the community for bringing together people living with dementia families to take part into informal social activities and also engage information and support. So it's a much more informal way of sharing ideas, sharing information in a normalized way. So taking a closer look at this Alzheimer's Cafe movement, the educational aspect is one part of this session, but it is combined with the therapeutic social aspect, which is critically important because the social aspect is meant to break down the stigma associated with talking about dementia. So there are three broad aims. One is to provide information about the medical psychosocial aspects of dementia. So for example, a nurse from the community, from the hospital can be present, or a doctor can be present to talk about the medical aspects or the psychosocial aspects of dementia, but it goes beyond that and talking about more informal lived experience of the people who are living with the condition. So it really gives a forum to speak openly about dementia and with the idea of empowerment, emancipation of people living with dementia and to prevent social isolation. There's a program called Dementia Supporters in Japan. So Japan is one of the countries that has many innovative programs in the dementia-friendly community context. This particular program called Dementia Supporters has a goal to provide, similar to Dementia Cafe, provide informal, practical, and psychosocial support volunteering in Dementia Cafe or support group, which also has a different interesting dimension, which is called Dementia Friends Champions. So these are individuals who are going through, who are part of Dementia Friends, but they actually volunteer to provide training to other individuals, other community members to broaden the reach of the initiatives. And the Dementia Friends Champions include a number of people who are living with the dementia as well. These are some of the other programs that are in Japan: early stage dementia intensive support program for early detection and support for local residents. SUSS Wanderers Network, this is an important program which is about dementia training volunteers and advocates to help search for missing people. This has a lot of extensions and variations across the world. One of the things we are looking at in Canada and in Americas is that we don't have incident reporting of people when people get lost. So we're working with law enforcement, for example, to really have a program in place to have documentation when somebody gets lost, and also expand that to more not only volunteers and advocates, but also technology and working with engineers and computer scientists to develop apps and appropriate technology to help people who might get lost for them to return back home, or also people in the community support network to find people who might be missing. Bridging Communities, Sharing Our Memories is another program in Japan, which is a program for high school students to visually document people's life story histories. This is also a critical important part in terms of understanding and documenting people's life stories, which really help in reminiscence, help understand people's abilities and capacities as they move forward in the different stages through the condition of dementia. There are a few good programs in Canada. One is Paul's Club in British Columbia, which is a group social activity and outdoor walking program for people living with dementia led by volunteers. So this is a group that goes on walking trips, outings every few weeks. And that's part of a way to interact with each other in a meaningful way and a socially supportive way. There's a Blue Umbrella program initiated by the Alzheimer's Society of Canada, which is a training and education program for businesses to provide more dementia-friendly service by training their staff and employees. In the UK, there are many programs like Japan, and these are just a few. Connecting Communities is an interesting one, which is a culturally sensitive awareness raising activities. So these are ethnically diverse communities who really have programs to raise awareness and also develop best practices toolkits that can support service providers. So that reach out not only to the community, but also to the service providers in providing culturally sensitive toolkits. The next one, Happy, Safe, Out and About, is a volunteer buddies program who are matched with people with dementia based on the skills, interests, and provide help at the home or out of home. Drivers for Change is a training program for bus drivers to inform by consultation in consultation with people who living with dementia and families. So this has been extended to also taxi drivers in recent times. Slow Shopping is a program to provide participating local stores. It can be grocery stores, it can be other stores, having designated times within the day, within the week, when there will be dedicated slow shopping times where cashiers and will be more aware that there may be people with special needs or people with dementia coming in and they may need some extra time as they're checking out. There will be also support by trained staff within the store to greet people and provide support. In the United States, there's an interesting program, and there's variation of this program in other countries. Meet Me at the MoMA. MoMA stands for Museum of Modern Art in the New York City, but this program has expanded to some other cities in the US and some other countries as well, which is a monthly museum tour program for people living with dementia led by an educator. In Australia, there are several programs. I'm mentioning just one. It's called Side by Side program, which supports people with young onset dementia to work at a local organization with the support of a dementia trained volunteer or an advocate. Oops. So last but not least, I kept the best one for the last. But this is about Singapore. Singapore has a number of good programs as well. I want to mention a few ones here. So these are courtesy of my colleagues at Singapore ADA, Alzheimer's Disease Association. The first one is called IDEAL, Integrated Dementia Assisted Living. This is an exciting program that is being currently piloted as we speak to support people living with dementia to age in place. It's a collaborative project with a grassroots team at a rental block in Singapore, working with a number of people who live with dementia in that block. And there's support service in place in that block, a daily program and supporting the quality of life. So this is a really interesting, innovative program at the community level, at the right where people are living in the HDB block. Voices for Hope is also a fascinating, innovative program. It's 8-week empowering program towards self-advocacy for people living with dementia. And at this point, there are 55 people living with dementia caregivers. It's a dyad program. People living with dementia and their caregivers come as dyads. And there are 55 dyads have graduated at this point who have shared the stories in more than 100 occasions with TV, radio, and other social media. There are memory cafes in Singapore, which are weekly sessions with engaging activities in actual public cafes. There's a meeting center support program, which refer to the small community-owned clubs that is for people, residents with dementia, using the adaptation to change model, which is another model and that is active in Singapore. And finally, enabling places of worship, which is currently suspended due to COVID, which is utilizing the space and volunteers in churches in 4 churches currently running, before the COVID situation, weekly 3-hour dementia activity sessions for the church members, including spiritual care. I know there are other programs from MOH and AIC in Singapore, but in the interest of time, I'm not mentioning those here, but I know it's an incomplete list here. So moving on here, the last segment of my presentation is addressing the issue of dementia built environment. So we know that the neighborhood context is a critically important part when we talk about people's quality of life, because people living with dementia need to go out and socially participate even after the diagnosis and have a normal life, as all of us do. So the out-of-home activity and social participation obviously take place in the neighborhood context. So within the neighborhood context, the built environment is particularly important in enabling or disabling mobility, orientation, and wayfinding. There are a few studies that have been done that have looked at people with dementia, the mobility and participation of people living with dementia. And for example, in a study in Canada, we compared people living with dementia and people who don't have dementia. And we found out that people living with dementia talked about they're likely to visit fewer places in the community as they move forward in the trajectory of dementia condition. So we need to look at which are these places and how can we make meaningful interventions in these places so that they can continue to support people living with dementia to come and visit and be actively engaged in those destinations. So built environment is an important part of focus when we talk about research policy and practice and dementia-friendly communities programs. And these are very quickly a few planning and design guidelines. So one is the familiarity, which is about function of places and buildings should be readily apparent. So are we looking at a convenience store? Are we looking at office? Are we looking at what is the function of this place? That is an important part of familiarity aspect. And this also leads to when there are renovations and changes, developments, new developments happening in the community, we really need to think about which are the more important familiar spaces that people frequent, people living with dementia frequent, and try to conserve and preserve those places. Legibility is an important planning and design guideline, which is about hierarchy of street types, having smaller blocks, having irregular grids, and having clear and dementia-friendly street signage. So this has this legibility aspect of several planning and design subcomponents as well. Distinctiveness is about variety of landmarks, including historic buildings conserved, not only historic buildings, but distinctive structures and features like public art that can be developed. So this is a very critically important aspect because this distinctiveness aspect is related to the issue of wayfinding and orientation for people with dementia in the community. Accessibility is about mixed land use, not only single land use. So mixed land use really help more easy access to amenities and services in the community. And the idea, an important component of this accessibility is key destinations in the community should be located within 5 to 10 minute walking distance from somebody's home. So I'm nearing the end of the presentation. This is a figure that combines the different design and planning principles in terms of dementia-friendly neighborhood built environment. And there's an overlap with age-friendly age-friendly environmental principles. So very quickly, the one on the top one, which is walkability and land use strategies, and one on the bottom, urban design for safety, comfort and safety. These are principles and design solutions that we talk about when we talk about age-friendly built environment in the community. And the middle is one that is really addressing issues of people with dementia, about wayfinding aspects. And you see they overlap quite a bit with the top one and the bottom one. So all of these are relevant for dementia-friendly neighborhood built environment. And they need to be part of dementia community planning initiatives and urban design initiatives. My final slide is to give a nod to some of the good work that has been done in Singapore. These are examples of planning and design guidelines for dementia-friendly, and dementia-inclusive environments in Singapore, sponsored by the Ministry of Health, AIC, the SUTD, Center for Innovative Cities, ADA, and many other organizations have been critically engaged in the development of these neighborhoods. I think one important note as we look at these reports is it's important to support innovative programs. So it's one thing to have these guidelines in place, but we really need to support, number one, implement these principles and guidelines through policies and regulations. We need to support innovation. And thirdly, to really do evaluation of pilot projects and innovative projects. With that, I will conclude my presentation. Thank you very much for listening.
Thank you very much, Prof. Habib. It's been a delight to have you as the keynote for today's session. We'll have you back in the panel session later, moderated by Dr. Corinne. Next, I would like to introduce our speakers. Prof. Lee, he's the Director of Community Engagement in SingHealth Community Hospitals, as well as Dr. Catherine Chan, who is the consultant at Bright Vision Hospital, SingHealth Community Hospitals. So the topic that they will be sharing with us is from community hospital to communities of care. So may I now invite Prof. Lee to take over the sharing of the screen.
Thank you, Kelvin. Good morning, everyone. I hope everyone is healthy and safe from COVID. I'm sure all of us are monitoring the clusters of community cases that we have right now. But not to worry, we are on top of the situation. As we all well know, Singapore is voted the safest place to live in during the COVID pandemic. So we are in the best possible place. And truly, we are in the good state because we are very effective as a healthcare system in tackling issues like COVID-19 outbreaks. And the secret really is because we have a government that is very efficient and very trusted by the people. We have healthcare professionals who are very well trained and very well equipped, thankfully. And then we have communities that are very well organized and very disciplined. So with all these three elements, our healthcare system really is very effective. And that's why we come on top of situations quite well. But how do we exactly fare when it comes to being a country that's the best place to live for elderly persons? So I took a look and I saw this survey done by HUK, NGO that's quite trusted. And guess where Singapore ranks? We are not the first, we are not the second, we are not even the top 20. We are on the top 26, not too bad. But then you see that we are below countries that we usually compare ourselves with, such as South Korea, Japan, Taiwan, and such. So there's some distance to go, but as you can see, as you heard from the previous speaker, there are many programs in place. And I'm very confident that with these three components working together, very soon Singapore will be again top of the tops. So next slide. So I'm going to talk about my colleague.
We can't see your slides.
Oh dear.
Yes, it's moving now.
It's moving now?
Yes, it is.
Yeah, okay, thanks. So my colleague Catherine and I will just talk to you from the healthcare perspective, but not really from the top of the totem pole, but we are at the intertidal zone or the interface between hospital and community, called community hospitals. And many of you would have heard that our government really focus on these three trusts: beyond hospital to the community, beyond quality to value, and beyond healthcare to health. Next slide. So we are sort of one of the three clusters. We are in the eastern side. So you'll see many familiar logos like SGH, KK, Sengkang Hospital, Changi Hospital, and all the cancer centers and so on. But you'll notice this little green man in the heart, with a heart in a box. And that's where I work in, SingHealth Community Hospitals. We are a cluster of 3 community hospitals and the largest provider of community hospital services. And then the other part of us that's really embedded in the community is SingHealth Polyclinics. I'm sure many of you are familiar with. And then we are also part of this academic medical center because of the Duke NUS Medical School that we are working very closely together. In fact, we are integral to one another. So next slide. So not all of you may be familiar with this community hospital concept. Thankfully, most of you will be too healthy to need our services. But if you have elderly persons who have a serious bout of illness and a longer runway to recover, then you know that community hospitals play a very important role. In fact, when I present it to overseas colleagues, they're quite puzzled as to what is community hospital, because they don't have such an equivalent. The closest they have is called a skilled nursing facility, which is like a nursing home with slightly more medical care. But we really are a community hospital that is really integral to the system. In fact, we are the one that bridge the acute hospitals to the community where the patients originate from, and we want to return them safely too. So a typical patient, elderly especially, with a serious bout of illness, will become seriously deconditioned and destabilized from their normal activities of daily living. So a quick stay between 4 to 6 days in one of our acute hospitals, which are really world-class, they would have figured out what is the medical problems, and most of the cases have a good kind of treatment and in place. But to return back to community, there's a long runway, and sometimes they need a longer runway, especially those who don't have optimal social determinants of health and those who have suffered significant disability. So they come to us, a hospital that is very cost-effective, where there are more therapists than doctors, where we use care more than technology. And after staying with us for about average of 21 days, we put them back on their feet and return them to the hospital, to their communities and their home. Next slide. Next slide. So this is the chasm between the acute hospital and the home, and it's really bright. It's really wide. And then sometimes in the bad old days, when we let patients leave the acute hospital, we really keep our fingers crossed and our heart in our mouths, and we just wish them best of luck, because we know that the moment they leave the hospital and reach home, everything unravels. So there are community hospitals like now like us, and there are many other services, transitional care programs, and so on. And we are rapidly making this dangerous chasm much safer, and the drop in voltage much lower and more gradual. Next slide. Next slide. Okay, so now, so I'd like to hand over now to my colleague, Dr. Catherine Chan. So just a very quick reminder again that we are part of 3 community hospitals, the oldest of which is Bright Vision Hospital, which is 20 years old. I think not many of you, it's not a very famous hospital. It's very small and very compact. And the people who work there are very proud to be part of this little kampong Napiri that we refer to ourselves. It's found in Lorong Napiri. And then we are now presently a dedicated COVID facility, but once COVID stands down, we are going to repurpose this hospital. And this gives us a very good opportunity. A small, compact hospital with a strong culture of care could potentially be a good experiment for us to pilot, to see what kind of hospital will really meet this vision that we have of being able to transit patients safely back to the community. So with that, I'll hand over to Dr. Catherine Chan, who is leading our effort to repurpose our community hospital. Catherine, please.
Thank you, Prof. Lee. I would like to bring you all through a glimpse of what we are planning to do for our redevelopment project for our Bright Vision Hospital, which is located at Lorong Napiri. Okay, first of all, we always believe in the principle of person-centered care. For a patient living with dementia, not only just the neurological impairment, the health, their social setup, and their psychology, we need to know more about them. So we have a health journal, which we actually ask the patient or the family to write down so that they can share with our multidisciplinary teams in our ComHos about their likes and dislikes, so that we actually know about the strengths of the patient, and we can further promote patient empowerment through their journey in the ComHos during the rehabilitation or subacute care. So I would like to show you all some common examples of the patients which are already currently in the ComHos in either of our 3 sites. So first case here, you have a very younger, not say very young, a younger gentleman who have young onset of dementia, had a fall, did a hip surgery post-fracture, and now he's in the ComHos for further rehab. So our main aim is to make sure that he's actually active after rehabilitation and continue his journey in the community. The second case here is actually an elderly gentleman who live alone in a rental flat, which is not uncommon in Singapore. So we noticed that he had many frequent admissions for falls. So this time round, we actually pick up that he has newly diagnosed cognitive impairment. So our aim for this case is how can we make sure after rehabilitation, he can continue to live safely and independently in the community as long as possible. So moving on to the lady here, is a known nursing home resident already. This time she actually came in for a wound care, and she also had a multi-drug resistant organism from the wound itself. So this lady has a known background history of advanced dementia. For this case, we would like to work with the nursing home for the future preventive care for this patient. At the same time, explore about quality of care for this lady for her so-called last journey with advanced dementia. And of course, last but not least, you see this lady who looks quite feisty. I suppose this will be one of the cases that a lot of family finds difficulty handling. They're actually cases of dementia with behavioral issue. Unfortunately, this admission, she had urinary tract infection and she got more confused and her behavior got worse. And because of that, she also had functional decline. So she's in a COMHOS trying to do some rehab while family members are seriously considering whether they still can cope and should they put her in a nursing home. So for such cases, we would like very much to do some caregiver training to help the family along and see whether we actually can postpone the so-called admission to an institution for this lady. So in the center, we have this caregiver. A lot of times we know that caregiver will have a lot of questions. What should I do now? Where should I go? How can you all help me? So in our COMHOS itself, okay, like what I mentioned earlier, what can we do to help all these patients? So first of all, we actually embarking onto early detection. Early detection is actually very important through structured screening and assessment so that we have a better understanding of the patient condition. We can give them a better design, individualized care. And early diagnosis is very important because proactive actions can be taken to provide them the post-diagnostic support, not just in COMHOS itself. It needs to be continued into the community. Next, we have the preventive care. So Alzheimer Disease International in 2020 actually released this new updated 12 dementia risk factor. As we know, as a family physicians who runs the community hospital, we are also, our strength is also in managing chronic diseases. So from this 12 so-called risk factor, we know that hypertension, diabetes, depression, obesity, physical inactivities, smoking, alcohol consumption, these are really part and parcel of primary care. It's not just for dementia patient alone, but for all patients. We need to educate them on the risk factor and at the same time encourage better management of this risk factor. And all this also continue down back to their community care in the polyclinics, in the GP itself. And this is actually one of the most, I would say, very exciting component for our COMHOS is really designing and put in a lot of cognitive stimulating and engaging activities for patients. So currently, we know that there is reminiscent therapy, whereby you can allow the elderly to talk about their past, bring back some memory, cognitively still engaging them. And then we can have activities which are more physical, like gardening, working with national park. We can build a therapeutic garden in our hospital, and then cooking sessions, and not to forget our younger generation. So we also hope to co-organize activities with community partners, such as secondary school, primary school, to promote some intergeneration kind of bonding. And last but not least, we also wanted to bring in technology innovation these days, as we can see that robots are very cute and they can be very useful. So recently we have a robot called Tammy, which actually can go around engaging the elderly. Sometimes you can have the video in them to lead some simple exercises itself. And last but not least, Dr. Habib mentioned about Memory Cafe. My wish is actually having a cafe in the hospital compound as well, whereby I can bring in patients with dementia and the caregiver, as well as volunteer. It's a place where they gather, they can increase the awareness, they can give each other support. And sometimes giving the patients with dementia a bit of so-called ability to run a cafe might be something that give them a pride in their life as well. Okay. We should not forget our caregivers. The 3 E's are very important as part of our program. We wanted to engage the caregiver in all stages of the care delivery. We need to enable them with knowledge, skill sets, and resources so that we can prepare them for their caregiver journey. And then empowerment is really a very key word these days, because for a lot of caregiver, you give them the empowerment in a cohort, maybe to help us with co-development of care plans, activities, including participation itself. They can actually continue all this back at home itself without the additional stress, because they already know how to carry it out, how to motivate the patients with dementia. And of course, if we can, we hope to develop a caregiver starter kit pack in the electronic version that we can share with all our caregivers. And of course, for ComHOS itself, as Prof Lee earlier mentioned, as part of a national dementia network, we are really the bridge. We actually link up from acute hospital down to polyclinics and GPs and all our community partners out there, as well as nursing home, to ensure care continuity for the patients. Because ComHOS stay is actually not long. Whatever we can activate, whatever we can diagnose, we can pick up. We really hope to do as much education we can, caregiver training, and then after that, handhold them and pass down to the community itself. And because, like what Prof mentioned earlier, we have the opportunity to really do some renovation. So we need to look into a therapeutic and safe environment. Familiar places, safety, security, comfort, and stimulating environment is actually very important in the neurocognitive design itself. So these are some thoughts that we have, that we wanted to have, which is still in planning. We wanted to have signs that are very big, very clear, easy to understand. And as you all can see from the middle picture, which is actually a very so-called style, Singapore style kind of coffee shop tables and chair, we hope to bring this in to give the patients a sense of the community, even though they are in a hospital. And as a garden city for Singapore, we also wanted to bring in a garden into the hospital ward itself. So these are some examples that we are thinking and brainstorming and hoping to develop for the future Bright Vision Hospital. And now I would like to pass this back to Prof Lee to talk about social prescribing.
So this is our last slide, and Catherine and I would like to end this presentation by apologizing to all the healthcare workers, because I have bad news for you and people like you and me. We are only responsible for about 20% of the health outcome that our patients receive. At the end of the day, the 80% is in the community, determined by the social determinants of health. So if we do not address this part, which lies in the hands of the patients, the family, the caregivers, the people living in the communities, social determinants of health like housing, the physical environment, educational level, socioeconomic status, and so on, then we will not have good outcome, no matter how hard we try in the hospitals. So in SingHealth Community Hospital, we therefore have started social prescribing, which is to improve the social determinants of health on an individual level, contextualized to the patient. So very simply, we have well-being coordinators, people who are not professional healthcare workers, but have the right attribute and the life experience to help patients. We give them the necessary training in social prescribing, and then we ask them to go and seek out resources in the community and assets in the community according to the asset-based community development theory. And then we are quite confident that we can help to contribute towards moving Singapore to be the best place for elderly persons to live in. And with that, thank you very much. I will hand you over back to our chairman. Thank you.
Thank you very much, Prof Lee, as well as Dr. Catherine. I think it's a very appropriate topic for us now that we will have the speaker. She's Susanna Harding. She comes from SAL Foundation. She's the Senior Director for International Longevity Center, Singapore at SAL Foundation. And the topic is about empowerment of older residents as community advocates in building an age-friendly community in Whampoa. So let's hear more from Susanna now.
Hi, good morning, everybody. I hope I'm clear.
Yes. You need to share your slides, Susanna.
Yeah, wait. I need to I need to find the share screen. Okay, there you go. Okay.
Yes, we got you.
Okay. Okay. Thank you for Kelvin for inviting me to be part of this webinar, and listening to our esteemed GOH and Dr. Habib and Prof. And Dr. From SingHealth. I must say that there's two things I heard clearly, which could be a good starting point for my sharing this morning. One is the data that says that 86% of our elders actually want to continue to live in their own place in the community. So I think that's very important. The second is Prof. Lee has mentioned that 80% of the outcome are actually determined, the social determinants are in the community, are kind of like has to be influenced, has to be worked out at the community level. So for South Foundation, we've known that this has been part of a very important component of successful aging. And since as early as 2009, when we developed a blueprint for how a highly developed city-state and with a very highly developed built environment like Singapore could actually age very well and successfully with all older persons from the well to the frail, and even those with living with dementia. So we developed it in 2009. We had a chance to be invited by the City for All Ages Committee to then pilot test it. And as Prof. Habib, Dr. Habib has said, it's very important that when you innovate something, you have to evaluate. And since 2013, when we went to WAMPO as a community to implement and pilot test our model of how a community could age well and successfully, has actually been continuing since 2013. So this is a continuing progress since 2013. So I'll be sharing, and at the core of this is that where the older persons are, the other residents, the family and the caregivers, as well as the different stakeholders, including the hospitals and the other service providers in WAMPO. So our vision of successful aging and COMSA has always been that it is about a community where older persons are actively defining and performing their civic roles with people of all ages, including people with dementia, where older people are coping well, not just physically, but also emotionally, psychologically, and socially, and they have an optimistic outlook in life. And the third important component for us is that there is a positive image of growing older in the community and of older persons themselves as holders of community history and as active contributors to society's productivity and development, even at the late stage of their life. Okay. Oops, I cannot move my slides for some reason. Oops. Okay, so at the start, the model, we have three pillars. One is actually the community development, starting from the older persons themselves, how they can, there's a bit of, oh, sorry, I cannot, some participants, could you please mute yourself? Okay, so the three pillars of COMSA has always been the older persons themselves and the family, how they can be empowered and continue to be able to take care of themselves and be able to determine how they would want to grow old in the community. And one way and one strategy that we have utilized is actually community development, We've also talked about having a very good care system development. So this is about identifying, understanding what are the community needs, who are the older persons in the community, what are the resources that are within the community, and how we can utilize and leverage on those resources so that then we are able to take care of every older persons in the different stages of their growing old years. And then, of course, as part of this is, of course, the infrastructure in the neighborhood, the built environment. They cannot grow old well without the built environment making sense of how the older persons can actually be enabled, continue to be enabled, and if there's some disability, how can that disability be minimized through the kind of like trying to restructure or renovate the built environment to respond to the different needs of the older persons. So we started by understanding what is the profile of Wampo's population. And we did a survey back in August 2014. There were about 1,375 residents aged 60 years and above who took part in this study. And Wampo as a profile, as an estate, actually has a higher percentage of older persons than other estates in Singapore. So there was 18% living there that are 60 and above. This is the kind of like allocation in terms of the public housing. But what we found out from the survey is that there's 10% have a cognitive impairment risk. 50% are socially isolated, 3% feels threatened or harassed, 36% of them never married, widowed, or divorced, 9% of them live alone, and 25.6% may not see a doctor even if they have to. So this is the background. So when the previous speakers and our main speaker has talked about trying to understand who are the people in the community, who are the older persons, it's very important for us to have this as a baseline so that then we know how then to respond to their needs. And then from there, we then developed the phase 1. As I've said, it's a continuing development in Wampo. We've had, you cannot create a community for successful aging in just 3 years alone. So since 2014, we've taken a very population approach into how we've conducted the survey. We developed a biopsychosocial risk screener for community case finding, which is really to understand who are the individuals, who are the older persons in the community that are at risk of care breakdown, so that then we know how to then pick them up early on, so that then we can address their needs early on and then be able to refer them if need be to other providers as well as to our own services within COMSA. The second is the community development. In the community development component, right from the start, at the heart of it is really about empowering older persons to be able to take care of themselves first and foremost, so that we can delay the onset of disability, but at the same time to continue to be part and parcel of community decisions, community participations, not just tokenism, as Dr. Habib has said, but really meaningful engagement and participation at the community level, being able to determine how they want to be able to continue to contribute and be part of the community, and how then they can be utilized actually as volunteers at some point as well. So in fact, in the early stage, in the phase 1, when we started working with them, one of the things that we have worked with the CFAA at Wampo was that some of our elders became volunteers and then work with the CFAA, the grassroots, to be able to assess how the whole Wampo is age-friendly. So our elders went about with the committee leaders and then identified what are their access, what areas need to be improved in Wampo. The outcome of that exercise at some point is that Wampo as an estate has become a senior-friendly zone. So there's been some kind of like redevelopment of the built environment within WAMPO to be able to make it as age-friendly as possible as a result. So that was part of the phase 1 that we have done. And part of the phase 1 as well is the service system development. Very important, the care. So we established the care management as underpinning care integration service. We started engagement of the different partners. It's very important that there is an integration of care from the GPs, the private there, the health and social care providers, the grassroots, the NHG regional health system, which WAMPO is part of, and then the development of a service network. So while we are talking about we're empowering the older persons, we're understanding working at the system level, at the community level, we're also trying to then make sense how the built environment could actually support this moving kind of like transformation of the community to make it as age-friendly and inclusive as much as possible. In the phase 2, which we have started, although of course with the pandemic, it's a bit of a struggle right now to kind of like have it as the way we have want to do it, but really about COMSA, which is actually co-located. I don't know if all of you know, COMSA Center is actually co-located within the WAMPO Community Club. So we occupy 2 spaces. So there's the community club, the normal community club in Singapore. Level 2, we have the primary care and a lot of our care services. And then we have a level 3, we are located at COMSA Center, wherein we have all the other services that we have right now. So, but the idea is to really COMSA as a one-stop integrated longevity central. And where there is a COMSA Center, which is where care system for older persons across the spectrum from healthy and active to the frail and approaching end life, including persons with dementia. I will show you a little bit, just to focus on what it is that we're doing with our dementia care system. We are an intermediary between hospital and the community. We facilitate space and opportunities for continued personal development, social engagement, strengthening family bonds, and the community development. So we are working with the older persons, the caregivers, the family, as well as the system, the different systems, whether it's the grassroots, the different service providers, as well as the residents themselves across all age groups. So this is how the key components of COMSA right now in WAMPO. So we have an integrated biopsychosocial care system. We've built on this. It's running, up and running, and if anybody's interested to see, please let us know. We're more than, although right now with what's happening right now, of course, visit is not feasible right now, but later on. So this is where we are. So we also have, just to give you emphasis, we also have, as part of continuous self-development and self-determination, we actually run learning room, as well as we have a space called COMSA Kawan, that is a space whereby older persons can drop in and then can initiate activities that they want to do themselves, among themselves and for the residents. So it's actually a cool space to, if you want to come and visit us. And just to kind of give an idea, because one of the things that has been a focus of this webinar is around dementia, how to build a dementia-friendly, dementia-inclusive system. As Dr. Habib has said, age-friendly plus dementia-inclusive is actually, so in WAMPO, we have actually also have this dementia care system, which focuses not just on the medical, but also the social and emotional care of persons, older persons living with dementia in the community, that involves, and this is the team, but it involves both the persons with dementia as well as the caregivers, and potentially also we're looking at the other older persons as working within this system, because we need their support as well as not just older persons, but the rest of the community, so that then everybody is aligned into how to support an older person with dementia in the community. I think one of the important component of COMSA as a model and as a living pilot innovative program in WAMPO in Singapore is really about empowering the older persons. as community advocates themselves being able to really identify what are their issues. We cannot tell them, or we cannot live their lives as older persons. They're the only ones who are living their lives as older persons. So they are the best position to say what are the areas that needs to make it as age-friendly and as the community as possible to them, so that they can grow old well and successfully in the community. So we have trained, and you can see from these photos, they are actually, I think the oldest is about almost 90. We have community advocates, and they actually have been identified 3 issues that they have been working on. So this is a continuing one. And if you notice, 2 of them are actually built environment. So when you ask the older persons what are the issues that you find in the community, they identified 2 that are every day they experience, and when we try to understand it, and they told us what this. One is the overhead bridge, which is actually, as you know, Whampoa is connected. The 2 sides of Whampoa is connected by the overhead bridge because it runs through the CTE, the highway. And the other one is the transport, whereby it's really an issue among the elderly in terms of their ability to move around and be able to get to the services, or even be able to participate and join and go out and have the chance to see and live life outside of their homes. And the third issue that they worked on and they continue to work on is the social isolation. They know that they have neighbors who are socially isolated, and they would like to help them. They would like to be there and become befrienders to them. So there's actually now a befriending group that has born out of this experience that we have. Yeah. So for that, I think that's more than enough as a starting point. And then if there are questions and if there are interests, I'm more than happy to share more later. Thank you.
Thank you very much, Susanna, for your kind sharing. Now we're going to turn over the session in the panel, and we are very glad that this morning we have Dr. Corinne Goh. She is the consultant at the Aging Planning Office in Ministry of Health. And so now I'll pass over to Corinne. Would you mind take over the panel session this morning? Thank you.
Sure. Thank you, Kelvin. I hope everyone can hear me clear. Okay, right. We have 20 minutes for panel discussion. And I think you will agree with me that this morning we are already very enriched with knowledge internationally and locally, medical settings and the community settings on developments. And I think I am very impressed with the advancement of the approach and services programs that's been in place in Singapore. Having said that, I think dementia is an emerging phenomenon in our country. And this is a growing area where I think in terms of knowledge building, in terms of service provision, and how do we mobilize communities, it is an evolving journey. I'm so glad that from the speakers, we can hear that we have got started. But then I think, as our guest of honor said, right, the journey is evolving and we will never be satisfied. We will continue to strive to learn new things. So now I would like to spend a bit of time getting the panel speakers to talk about dementia issues and how we can continuously progress in this area. Perhaps I could start with our keynote speaker, Dr. Habib. He has given us very good principles, concepts with regard to dementia, building dementia-friendly community, and so on. And I would like to ask him, from what he knows about Singapore, how can we translate or apply some of your concepts that you have said into Singapore's public housing, so that we can embrace a more empowerment-based environmental approach to building a dementia-friendly neighborhood. So then after which I think Susanna and Dr. Lee, and Dr. Chan, you might want to chip in too, to also share from your perspectives on this topic. So maybe let's begin with Dr. Habib, please. Thank you.
Sure, thank you. Can you see me?
Yes.
Okay, good. Thank you, Dr. Corinne, for facilitating this panel. Thank you for the question. Yes, and first of all, Singapore's built environment is actually quite unique in terms of what has been achieved over the last few decades. The most important aspect of the built environment would be the public housing. As we know, Singapore's population, about more than 80% people live in public housing, and public housing in Singapore is a success story all over the world. So when we look at the public housing itself, and that's really the key important, the key setting in which we are addressing some of the issues that we are talking about. So as we know, as was mentioned by others, that there are new purpose-built housing are being built. For example, Kampung Admiralty as an example of independent living, for example, as an example, or the continuing care community, which is assisted living, which is being built at Butik Batok, is a good example. So we will see these happening. These are purpose-built seniors housing for more active older adults, as well as people who need some support, like the Butik Batok project. But I think what needs to happen, I would be interested to see how that continues to happen as purpose-built housing. But at the same time, what are we doing to support people aging in place in the community itself where they're currently located? So going back to the HDB housing again, the public housing in Singapore has number of positive features. I would like to quickly point out. One is the high density housing. So high density is a critically important part to provide amenities in an economically feasible way, which is also happening in many areas. We have the hawker centers, we have seniors activity centers, we have some of the MRT stations are quite close by to the public housing. So the hardware is there, the facility, the buildings, the void decks, the lower decks, which is used for many purposes, are there. But I think what we need to do is think creatively, innovatively, to see how we can bring in more functions and leverage the current spaces. So leverage the current spaces, but by that I mean the void decks, for example, as a space that is already there. The spaces beyond the void decks, the spaces between the different buildings, the different blocks within an estate. So there's an open space there. And it doesn't have to be like a new high rise, but there can be low rises built there. So thinking about the spaces between blocks within the blocks of the void decks, these are like a spatial resource that can be maximized in terms of different functions. In terms of the process, I think it would be helpful to really think about what we call community asset mapping. So looking at what are the community-based resources that are out there. So for example, the Whampoa project is a good example of senior volunteers. But beyond senior volunteers, who else could volunteers? Can we bring in youth as volunteers and other people who can participate? And within this asset, beyond this asset mapping process, to invite community groups to offer pilot projects. So I know some of the pilot projects that we're talking about, my understanding is they're mostly organized, initiated by government entities or local bodies. But I think there would be a way to actually invite local informal groups, citizens who are living in these housing with a high concentration of seniors, for example, to take initiative with the support by the government bodies to do some pilot projects. So the pilot project is a really important way to try out, experiment ideas, but that needs to really have a shift or more focus on community level, grassroots level initiatives. And I think it's an interesting issue for Singapore, in my opinion, as an outsider, because Singapore is really a success story from how the government functions, how the government entities, programs function really well. But at the same time, there is this issue that government is doing such a good job. What can we do as a community, as a grassroots level? So that is why I think there needs to be some incentive, some persuasion, to really motivate and engage people who are living in the community to take some initiative with some support, with some pilot funding program to experiment new projects. And again, once we have approved an experimental project, when we support an experimental project, pilot testing, the evaluation comes in very quickly. But this is really the way to go back to the aging in place. How can we support aging in place? And we can do this purpose-built housing, which are happening either independent living or assisted living, and that will happen. But in tandem, we need to focus on, in my opinion, to the public housing itself and how can bring in more services and support, both formal and informal. And then again, very quickly, the project that I mentioned, where ADA is directly involved, the IDEAL project is a really innovative project. So we will see how that works. I hope that will be some success story, but this is a good example to draw from.
Thank you. Thank you so much. Yeah, so actually, Susanna, Dr. Habib actually brought up a very good point that besides hardware, looking at void decks, I think the building communities cannot do without the human factor, right? So then maybe you could share with us from COMSA's experience, how do you build this in, to empower community? How do you get them to start doing beyond waiting for government to direct them to do things? How do you empower them? Could you share with us some tips on what works at the ground? Thank you.
Just to kind of like say to Dr. Habib, actually, we have used the void deck spaces as community museum in the past in Whampoa. We actually had a roving exhibition of the work of the elderly, and we use it as a space to showcase the history of the community, as well as for the old objects and the stories behind those old objects by the elderly. So we use those spaces. The second is really around, when you say pilot projects and empowerment of older persons as a ground up, we've actually been doing that since as part of the COMSA. And as I've said, we started with empowering the older persons to be able to understand their own aging process. So coming from the biopsychosocial, and then from there, then we are actually leveraging on that confidence, that empowerment, to then make them go out and then understand that they can actually do something. So what are the things that has worked? So there are 3 projects. These are pilot projects, the one that Dr. Habib is looking for. The overhead bridge, the transport, and the social isolation are actually 3 projects that are being led now by our community advocates. These are the elders themselves. We've organized a stakeholders engagement with some government agencies like the LTA for transport. We had a session with people from the M&D side. So we actually, and this is led by the older person. So our role is facilitator and support to them, but they are the ones deciding on what it is that they want to do. So they are actually, and all these things, we are actually evaluating them. So what has worked is really, as Dr. Habib has said, we need to understand the community. Who are they? So when we did the survey, we did the profiling of who are at risk at the community. We understand. We continue to engage. We did community organizing. We had longevity parties to celebrate that older persons in Singapore are growing older. There is opportunity in growing old in the community, and we can age well in the community. So we utilize some of the fun activities components. We use food as one of the things that Singapore is some. So we kind of leverage on what are the current cultural and practices that could actually make it interesting for older persons to come out and join the activities, but in a very structured way. So it's a very purposeful and structured way of organizing older persons. So now there is a group of older persons. Before COVID, about 100 of them meets once a month, and they continue to have socialization, learning, as well as being more socially active and trying to understand how they can actually support other older persons and other residents. We also had a chance through the community museum project we did in the past for 2 years with NHB support, we actually had a chance to have some intergenerational. So we actually work with the school within WAMPO and the art school in Singapore, and then together working with the older persons, they actually developed that exhibit, which went around all over the whole of WAMPO. So we are doing all these things. We have been doing all these things since 2014 when we went to WAMPO.
Thank you, Susanna. I think what I hear you clearly is about knowing the people, right? And knowing what takes. How do you motivate them? I think this is not easy because allegedly, right, some people at the ground were working with seniors, say that seniors are pretty lethargic, you know, they are not moving. And I think I like the idea about food, fun, and these are drawing factors that get the seniors out, you know.
Just to also emphasize Korean. One is it's really also the trust in the community. We need to be able to trust them that they actually can do it, because otherwise it's also very difficult, you know, like that mindset that everything is being done well by the government. There's nothing, but we trust that the older persons are actually able to do it themselves, and that it's safe for them to do so. So we also had to kind of build that sense of safety for them to have a sense that it's okay for them to be part of this process.
Exactly. I think this is so important. Trust. I think this concept is linked to empowerment, isn't it not? Strengths perspective, because if we view seniors as just in need, then they're quite in deficit. But we see them as strengths, then we'll pull them out, right? To do something for themselves and for others. Now, I want to move on to Dr. Lee and Dr. Chan. I think you have quite a not easy job, you know, transiting patients from a very structured environment where they can be well cared for in the built environment to the community. And it's excellent to hear that you have come up with very innovative strategies of social prescribing and so on and so forth. So maybe you can share with us from your experience working, what are the factors that worked well in transiting clients or family seniors and working with family caregivers to the community, and what worked well to help them continue life in and age in place? What are some of your observations or your thoughts? Can't hear you, Dr. Lee. I think you're muted.
Yes. So if I may start, I'd just like to say that what Susanna and Prof. Habib said really resonated with me. And that is the very important thing, is that it has to be community up. And sometimes when the top does too well, it sort of stifles the effort to come up, you know. And being part of this big healthcare group, we are sometimes guilty of this. So in our effort to bring the patients back to their place of stay, they live in a home, and the home invariably is part of a community. And from our work, we realized that Singapore is not homogeneous. There's a self-organizing element. Like, for example, WAMPO started because there was an area of need around this community called WAMPO. And they invited SAL and the local leaders work with them. And then that, presto, it came out with something very beautiful. So we also realized around our hospitals, there are natural communities, and these patients need to go back to these communities. And there are assets there. So one such project was that I was involved in. I went to visit one of these communities. So I went to visit this BWO, who introduced me to a group of elderly folks who are taking care of a garden that they have set up. So, wow, fantastic, right? Social prescribing, can do gardening and so on. And then as I talked to them, I realized they are very, very positive and energetic, you know. And again, like what you say, relationship and trust. Once you build that relationship and trust, they really open up. So they were telling me, oh, they want to do so much more than just do the gardening. They want to go around door to door to visit other elderly to find out how they're doing. They realize that many of them have returned to hospitals, and suddenly they don't see them back in the coffee shops or the hawker center. Can we help them? And they asked me, oh, can you teach me this? Can you teach me that? They know what they need to learn and what they want. So sometimes a bit over-enthusiastic. I was a bit worried. They want me to teach them cardiopulmonary resuscitation and so on. So maybe there's a bit too much. But I see that energy, and that's what ABCD describes, you know, the association, the spirit of association that comes naturally. Don't hinder it. I mean, you don't say, oh, you shouldn't do CPR. Just listen to them. maybe teach them first aid first and step by step go on, So it's out there. It's how we allow self-organization to take place. And my wish is that lots of ComSA will sprout out around, and then that makes our job so much easier. Because sometimes we thought there's nothing out there. I think sometimes we lack trust ourselves as healthcare workers. We only trust ourselves. We better do everything for them. Once we leave our hospital, oh goodness, they're going to get into trouble. I better be there. But I think we should look for assets in the community to help the patients. So I don't know what Catherine thinks about this.
I do agree with Prof. Lee because it comes from my personal experience when I do home care as well as I go with my occupational therapy for home assessment. A lot of times we are very worried. Maybe we are too protective of the elderly. We didn't explore with them what they have in their community. So once you go with them, you see how they're actually coping in their community. We shouldn't really over restrict them just based on our own perception of what is considered safety. So I really do encourage ourselves as a whole team, actually go out and interact with the community, know what they are doing. So for us as a short stays, even up to 20 days, 21 days, we actually could educate the patients and then introduce them to the community, which they may not know because they like to keep to themselves. So as a part, once we know what is out there, we can actually tell them, look, this is actually very good for you. Do you want to try? Give it a try and see how things goes. And a lot of times they are actually quite surprised as well that, oh, I do have this in the community, which I didn't know. It's just like recently I went down to Whampoa. I was quite amazed by as I walked past the so-called the river, where they actually put up the art pieces along the lamppost. I was very amazed. It's like, how do we bring in art actually into a garden, into a river itself? Yeah, that's all I have.
Thank you. Thanks, Dr. Chan. Now, we spoke a lot about people power, right? You need to energize the ground. I want to ask another question because I picked this up from Dr. Habib's sharing just now about collaboration. So collaboration in this context, I would take it as stakeholders, service providers, government included, right? How do we then work best to make things happen at the ground? So I would like to ask, now we have only 2 minutes to go, I think. I think Kelvin is telling me that the time is coming on. So maybe in 2 minutes, 3 speakers, you can share with me some key observations on what will make collaboration work at a higher level, that we can get going, and pave the ground to do more things. Yeah. Start? Yeah, yes.
Yeah, I think for us, what worked is really understanding where they are coming from, whether it's the grassroots, whether it's the service providers, where is the NHG, the regional health system, or even the other stakeholders in the community. Where are they coming from? What is in it that we are doing, we want to do together with them that would make it a win-win? So like all the activities that we have done in Whampoa, we've always said our main partner is of course NHG as well as the grassroots, right? The Whampoa CC, the grassroots leadership. We always shared whatever it is that we have achieved with them in a way that allows them to also own it, co-own it. And that's actually is important. One of the key, I think, that has worked with us, that partnership doesn't mean that it will only kind of like only my KPI, not your KPI. But what I always say to them, whatever it is, whatever events, how many elders attend, that is something that you can also be proud of and say that you have done it as well. So we shared all those things with we've been open, we've been invited them in all the activities, and we've always reached out. So we also constantly provide updates and monitors at the different levels, at the different stakeholders. That's why there's at some point we had a service network in Whampoa. So network and that kind of thing is one. Relationship with the grassroots, as well as we have an advisory board at ComSA level. So there is an advisory, so that different levels you are able to keep track, and then everybody understands what it is, and also a way to kind of, if you want to advocate something, that's also a good way, because you need some resources as well, right? So it's a win-win in that sense. So win-win, find
It's
yes,
a
transparent
common
and
goal.
opening. Yes.
Yeah. So Susanna is saying strike a common goal and communicate. What about Dr. Lee and Dr. Chan?
So Corinne, the word you use, one word is called trust.
Trust.
Just make some, and because just a very quick elaboration, it's not about funding, because funding is never enough. It's not about technical competency, because there's always need for improvement, but trust will make all this go much, much further. So I believe in trust.
Thank you. Dr. Chan, any words of wisdom for us to make collaboration work?
I guess it's for you and for all and for me. Yeah, because I'll grow old one day too.
I like this perspective. Yeah. So we are investing for our future actually, by the work we are doing now. Thank you so much. And Dr. Habib, words of wisdom from you on how we can work better, to move things forward.
Yeah, very quickly. I think that we're talking about, like, I'm just addressing this issue from collaboration among not the community per se at this point, but among the different organizations in the community, like government extensions and other bodies. And even though they are interested in a project, we see that they are not talking well sometimes with each other, and there's not a meaningful cooperation in some cases, even though they are working on the same project. So I think it's important to draw from other examples, like, nursing home setting, we talk about redefining the job description of frontline worker. The frontline worker should not be just giving the personal care, but maybe they should perhaps give some activities and other things. So there's an aspect of job description. Who does what is important. And that goes back to the organizational level. Different entities have a mandate, and that mandate becomes a barrier at some point. So when we talk about collaboration, meaningful collaboration, it's important to think about how can we be more flexible as part of a multidisciplinary group. And in some ways, the job descriptions and mandate of a position or a mission can need to be blurred and need to be fluid a bit more, so that a team can work more effectively. And of course, there are always issues about language and what is the motivation of different organizations. So essentially, my point is that in order to have meaningful collaboration among the government or NGOs meaningful way, there needs to be almost like a pseudo training program and revision of some of their assignment for that particular project vis-a-vis their own home organizations.
Thank you so much. I think I hear keywords: flexibility, the people factor, right? And then technical competencies as well, like Dr. Lee said just now. Okay, so due to time, I need to bring this panel discussion to a close, unfortunately. I think we can go on and on discussing very critical topics. I would like to thank our speakers here today for sharing your knowledge and your expertise. Really, we have learned a lot from your sharing and from the panel discussion as well. So on this note, I also want to wish everybody, good day and take care. Keep well. Yep. Okay, goodbye. Thank you. Hand over to Kelvin, please. Thank you.
Thank you very much, Dr. Corinne, and all the panelists for your valuable points, and also notes that we could take and improve on the care of our seniors.